Great, guys. So thank you, everyone, for joining and for sticking around. The room's cleared out a little bit, but we should have a great session for you guys right now. On stage with me are two of the sharpest minds in Medicare Advantage, Mark Newsom, Tom Kornfield. Both have extensive experience both in the public and private sector. I'm pretty sure most of you have come across their work especially within the last month or so. But both having worked at CMS and both having went consulting firms. So we are super excited to have them, and there's a lot to dive into, but I want to be mindful of everyone's time. So if you don't mind, I'm just going to sort of jump right in, guys. All right. So I want to sort of start just generally framing what has come up a lot today, especially around the advance notice, risk adjustment, and some of those things that are foremost, in our minds right now. So if you could each just take a couple minutes to share, where do you see the state of Medicare right now with these changes? Is there something that you sense is changing overall? Is it sort of just par for the course? You've run across it before, but I'd love to hear your insights, both of you, sort of where you see this going or what you think this may indicate.
Sure.
Yeah, you're closest. So yeah.
So if I think about it this way, I think about how things have changed over time. When Tom and I first worked together at CMS, only about 15 to 18% of the beneficiaries were in Medicare Advantage at the time. Now we're up to 51%, 55% if you take just the eligibles. So an incredibly popular program. And if you look at complaints are down. If you look at CAP scores, the customer service is up there. In fact, CMS publishes CAPS numbers nationally, and MA generally outperforms most, if not all, those measures. Look at stars. A lot of talk about right now that there's headwinds there, but that, if you look under the hood, it's because CMS is increasing the cut points in most measures. Oh. All right. I think you could hear me without this, actually. So if you look under the hood, this last year, about 2/3 of the measures, the cut points went up. Why is that? Because plans are performing better on that. So those are all good wins. But what happens when you win a lot? You get a lot more attention. And so here we are, where the agency in the Hill is looking at the program more and saying, as is common in this town and in 7500 Security Boulevard, what have you done for me lately? And what this administration's basically saying is, it's great all the things you've done, but we want you to do more. We want you to do more on cost. We want you to do more on quality as the way we see it. And that's reflected in the proposals that were in this most recent proposed rule and in the advance notice.
Yeah, I'm trying to think. I don't know, is my mic on? Yes. Okay. Sorry. I don't have Mark's voice, so I actually need the mic. I guess when I think about the advance notice, and Mark and I worked on them for many of them throughout the years, and read many of them throughout the years, and I did in fact spend weekends reading them, reading the comments that we received from. So I know there was a comment earlier about, did CMS actually read the comments, and I can confirm that yes, in fact we did read the comments on weekends. So with respect to the risk model change, I think what I want to kind of note, and I want to sort of start there because I think it's a pretty big problem. I'm just going to be blunt. From my perspective, what happened was there was activity that was going on in fee-for-service. It was corrected, and it actually has been adjusted in the benchmark, in the growth rate, right? So that was taken down to account for this reduced skin substitute spending, but they left that spending into the model. So how much spending are we talking about? Well, the old model, let's say it was $233 million total spending. In 2024, it was $10 billion. So that's 40 times more, right? So there's nothing else that increased to that level. And, you're welcome to go on my LinkedIn. I have a lot of different graphs and things like that I've put up there. But essentially what's happened is you see this massive increase for the coefficients associated with skin substitutes, and you see the coefficients for a number of other conditions have been lowered. And the problem with all of that is, there's multiple problems, I guess, but to sort of cover the two major problems that I see with it. One is the model is supposed to reflect what's expected to happen in the payment year. From that perspective, there's an understanding based on CMS's own policies that skin substitutes are going to be paid for differently in fee-for-service than they were in 2024. But the model doesn't reflect that. The model assumes you're going to spend, as much as you were spending on it. So now you have this very perverse incentive built into the Medicare Advantage program, if the model's, put in place, to find people with skin ulcers, basically, right? The second problem is that the rate book, there's a requirement in the statute for what's called actuarial equivalence, which essentially means it has to be on the same basis, the risk model and the rate book. But the risk model's on one basis, the rate book's on another. And so that creates a big problem. And I just want to close, I know I'm going a little long, but I just want to close just with like an example to show how impactful this really is. So, and I know this is one example, but, and you're all welcome to look this up as well. So if you take somebody who is 72-year-old female, Medicaid, has dementia, end-stage heart failure, specified heart arrhythmias, COPD, chronic kidney disease. The risk score under the old model, payment-wise, would have been 4.6. Under the new model, it's 3.1. So that's a 32% reduction. And so that's not yes, that's a hypothetical case, but the clinical profile that I gave, I'm not a clinician, and I'm also not an actuary, but my wife is always telling me, don't pretend like you're a doctor when it comes to some medical things my children are having. Nonetheless, there's a real possibility that enrollees with multiple chronic conditions are going to have lower payments under this model, and it's all because of a distortion in the payment, which Medicare Advantage was already very good at preventing in the first place.
You want to add anything?
This is why we have a comment period,
Yeah.
is to flag stuff like this. I think some of the other commentary that we heard earlier about we probably need a longer comment period, we probably need to be doing this year round. I think that's right. I think the complexity of the program, the scale of the program, the number of different players in the program from a provider perspective, from a plan perspective, the vendors that are out there, those voices need to be heard. And because of the complexity, you need the time to analyze the information and the data.
Those are great points. I think, again, because it is a complex subject for sure, but as we've alluded to at the previous sessions, it's something that we need to be mindful of and why the comment period is so important. So thank you for that, and thank you for helping explain it, Tom, because I, too, am not an actuary and nor pretend to be one.
And keep in mind, too, that some of the experts that are working on the rate notice are also working on the proposed rule at the same time.
Right. Well,
that's a lot.
Well, and that's an interesting point. As we think about this and, so much going on, and it seems like there are the same resources, looking at both. If you look at your time at CMS, how does one prioritize that? And especially when you're looking at, the changes we're talking about and, the potential, it's an increase, but a cut in supplemental benefits. How do you manage all that? Or how does one try to manage all that?
Coffee, no sleep, weekend. So, I think one of the biggest challenges for leaders at CMS, whether they're career or political, is you're really operating in three different times at the same time. You're operating in the current. There are beneficiaries enrolling every day. You have to assess their eligibility, entitlement, and enroll them. You're paying claims to providers or paying plans to pay claims every day. It doesn't matter if it's a holiday, it can be New Year's Day, it doesn't matter. Healthcare happens every day. You're operating in the past because you're reconciling old payments, you're doing audits, you're looking at reports and things of activity that's already happened to assess performance. And then you're working on the future, and that's the policy thing. So just because there's a rate notice and a reg going on doesn't mean all that other stuff stops, and you've got to balance all three, as well as interface with stakeholders. In my last role, I was probably doing at least 3 or 4 meetings a day and lots of email and things of that nature, while trying to balance with running the program and doing all those other things. That's a challenge. And the resources for the CM team that works on the plan side have been relatively flat for a generation, both in terms of staff at CMS and their contracted support. I personally don't think that's sustainable. And AI can help make people faster. But let me tell you, most commercial off-the-shelf AI models were not trained on what CMS does. And a lot of what CMS does is never going to be accessible to them. And most importantly, the decision-making. The administrator, the secretary, the president of the United States are not going to tell ChatGPT, come in here and record me and build a model on my decision, right? So that's real. So there's never going to be a commercial off-the-shelf model built to fit the decision-making that CMS does every day. It can do other things, and it should. And my last role there, we were starting to do some things with AI, and we'll see where that goes. But there's a lot of things that it's never going to help in that context.
Fair enough. Tom, any thoughts on any of that, or trying to juggle that, and where do you look for what's most important at the time and prioritize? Because all of them are very important to all of our beneficiaries.
Yeah, I think one of the things that I think sometimes gets lost is that within, it's not just CMS, it's also Office of Management and Budget, it's also, Health and Human Services and all those different all those different assistant secretaries that you work with. I realize there's been restructuring, but at least when I was there, and I know there's still, OMB, HHS. So those conversations and the clearance and those discussions, those, are also part of the challenge. And, preparing your leadership to have those conversations. So in my role, it was, maybe writing a memo or helping them do slides. And then, there would be a discussion that would then happen with different department heads. So it was kind of that was sort of the challenge. I'm sorry, I should have said not department heads, but, assistant secretaries in charge of different, offices within the, Health and Human Services. But I also want to comment on the AI piece because so I'm old enough to remember the Terminator and, the whole Skynet thing. And that's kind of how I had looked at AI for a long time. And I went to a session last year, and it sort of talked about the possibilities of it. And that allowed me to sort of see it in a different light. But I think it's always going to be a mistake to assume any technology is a solution. The technology is a tool. AI is a tool. It is a tool to help you do something well, but you have to know how to use it, right? And expecting it to come in and if you try to train it on information that doesn't have, it's just going to use the information that it has accessible to it, but it's not going to have the nuance. It's not going to have. Now, I understand future generations of AI may start to develop some of that, but you're still going to need to have people that actually understand the subject matter and are able to guide it and I think they can get great information out of it, but you need to have that expertise, and you need to listen to that expertise and trust that they're, moving you in a productive way. So I certainly welcome the use of AI. I think it does great things and can do amazing things, but you need to know how to use it. And I think a critical part of that, I would love to see more. And I don't know kind of how CMS is thinking about using it, but I think part of that has to be around making sure they really understand the programs and what they want to accomplish.
No, I think those are great points. And I think sort of understanding from a policy perspective, right? We've talked about a lot of things today. And what has sort of resonated with me is, especially when we talk, we had folks up here talking about the YMCA and supplemental benefits, and all of these things are interconnected when we talk about whether we're talking about AI working in CMS, whether we're talking about, how you're prioritizing. When we look at the C&D rule, what do you see as, some of the biggest challenges, around that supplemental benefit space? I know, there's thoughts about, how best to utilize those benefits, how best to, administer them, all those things, but they are all interconnected. So I'd love your thoughts, from a policy perspective about, where supplemental benefits should fall within this MA world.
In terms of the rule, I think the proposals around stars are going to have the biggest impact on supplemental benefits, and how that plays out in the quality bonus payment. The proposal specifically to remove 12 of the measures that are more administrative, the TTY measure or the CTM measure. I get the policy worldview behind that, and it's one I think a lot of people share, that those are not about clinical care, but those also happen to be measures that a lot of plans are doing pretty well on and had invested a lot of resources in over the last decade or so. So, just as a snap of the finger, responding to that and keeping your stars up is going to be a big challenge for a lot of players.
What's interesting to me about the rule is that I think it does reflect this is why, I know we've heard comments about stability and accuracy, and as I've said, I don't think that the changes in the risk model either promote stability or accuracy, for the reasons I described before. But with respect to the rule, it felt like that was where they were saying, hey, we know we're collecting certain information, maybe this isn't really useful, or maybe it's not going to be productive to just kind of push this information out to people. And I think there was a sense of, I saw in that a sense of reduced burden as I looked at it. There's the star rating changes, which I agree is going to have an impact. I think the broader challenges for supplemental benefits that I see are really more around the payment side, which obviously the risk adjustment is a piece of that. But the other piece that I don't think we've talked about at all today is Medicare Part D. And with all the changes from the Inflation Reduction Act, there's, I think, more and more premium and other changes, policy changes that CMS has made around Part D risk adjustment. There's more and more premium dollars that plans are having to buy down in order to maintain a zero premium plan. Sorry if I'm speaking to the choir on that, but, and I know there's been work on Milliman that's kind of looked at that. So, that's another challenge, and it's an ongoing challenge. I think that's going to continue. So I think from my perspective, the rule, I think, does a decent job of trying to pull back on some requirements that were seen as burdensome. But I think at the same time, the payment piece is problematic for lots of reasons.
I think it was a big important point for Tom to raise the Part D piece, because in Part D, 58% of the Part D enrollees are in MAPDs, and so all the challenges from the IRA and the Part D space are also impacting Medicare Advantage in a significant way.
Yeah, no, great points. I think, we've touched on a lot of different things here. So again, thinking from a policy perspective, how does that set us up for the next year? 12 months, 18 months? Do you get a sense or, where you think this is all heading, or is it pointing towards anything specific, or is this just changing daily and, we'll figure it out as we go along?
I'm hesitant to prognosticate since we're still in the middle of, the comment letters are in, lots of people are still lobbying, talking to folks. But as BRG, as you have spoken to, obviously, if there's not meaningful change in the final rate notice, it's going to be a tough year coming up. Last year had its challenges too, and we saw plans exiting the marketplace, reducing their footprint. We saw some benefit reductions. That's going to continue if we don't fix these payment issues.
Yeah, it was interesting this morning, Gable talking about the rural access when, in point of fact, that's gotten worse, notably worse, I think, in the last year. Their state, Vermont, MA is basically, is decimated there. It's not really available in some counties, and, obviously big payers pulled out. I guess, yeah, it depends on what happens with the advance notice, obviously. I'm not expecting much with respect to changes to the growth rate. Obviously, there could be updated data, and I know that can be taken into account by OAC. I probably shouldn't try to predict what OAC is going to do, because that's always been a bad idea for me for my whole career. But I will say that I don't believe that there's going to be a massive increase in the growth rate from that, and I think we'll see what happens with do they change the chart review policy slightly? I don't believe they will too much. Maybe some adjustment for new members, but then there's the question of the risk model and what they do, and we've seen there've been studies. I think there was a JAMA article or JAMA study that showed the number of people that have been affected by disenrollments. So we've seen some companies. When I first started in Medicare years and years ago, UCare was a mainstay in one of the original dual demonstration plans, and they're gone, right? And that's to me that's telling in terms of sort of the risk that plans are facing in this environment. So, and I think there's been other studies that have talked about plans, having kind of negative margins, right? In this environment. So I think if we see a rate notice which is similar to the advance notice, I think we'll probably see pullouts, withdrawals. We may see, I don't know if we'll see maybe we'll see increased premiums, probably reduced benefits. The other thing I would argue, though, and I know there's sort of some that, this is my opinion for what it's worth, but with respect to the model itself, I don't think it's correct to phase in the model at all, because I think it's just wrong. It's kind of a 2 + 2 = 5 is basically what the model says to me. So I understand that that's something they could do to kind of mitigate the impact, but I would argue that that's problematic, both from, it doesn't reflect what actual spending is going to look like on these conditions. It's going to underpay for certain conditions, particularly kidney disease. And it's also an inconsistency with how the rate book is adjusted.
Thanks. Well, what I'd like to leave on, or the last topic I'd like to touch on briefly, is we look through all of this, right, through the lens for our beneficiaries, right? What is best for our Medicare Advantage beneficiaries? So if you, had your druthers and you could pick, one salient point to make sure that CMS kept in mind when it comes to their beneficiaries, what do you think that would be?
I think that we tend to have these very in-depth conversations that are in the weeds and involve economists and actuaries and data, and I'm a data guy, and so is Tom. We love that. But that's not about the care that beneficiaries are receiving. That's not about their enrollment process. That's not about getting their claims paid or protecting them from fraud. So I would say instead of getting wrapped around the axle about payment, I would wish CMS would think more about the big picture of those impacts on the beneficiaries. And look, I've got family members in both original Medicare and in Medicare Advantage. I've worked in both. I want both programs to be better. Let's do better comparative effectiveness research of the two programs and figure out what works best, and then start all rowing in that direction.
I guess I'm kind of thinking about this in terms of what could make the program work better writ large for Medicare Advantage program work writ large for beneficiaries. Sorry, I don't know if I said that clearly. So when I think about the risk adjustment model, I know we heard earlier Chris Klom talk about, we don't want plans to compete on risk adjustment, but I think the incentives matter. I mean, that's just the reality of it. And so if you've built a system that's built on certain incentives, that's what you're going to get is, that type of behavior. So I'd love to see, well, two pieces of this. One is, and I think we heard this a little before, which is, I think a democratized, collaborative process whereby there's information that's shared as CMS is doing the research, white papers, open door forums, something where there's real opportunity to have feedback and dialogue between stakeholders and CMS. I don't believe that exists now. I know there are meetings, but I don't personally think that that's a way in which the public and stakeholders can have an opportunity to exchange ideas and hear what CMS is actually thinking about on specific items. And then I think the other is really kind of thinking about how do we, and we did see this in the request for information, but how do we move to a system that's different than the current risk adjustment model we have. I don't know if people really know this, but the current model was developed in the mid-1980s. I mean, I'm not kidding, it really was. So a lot of the aspects of the model are sort of been done years and years ago when the program was much smaller. And where I'm going with this is that I believe if we build the model, can work together towards building models that will provide the right incentives for plans in terms of how it's kind of integrated with the payment, I think that would be a better place for everyone to be. And I think that would be a better Medicare Advantage program where plans would be competing on, what matters in terms of, the care that beneficiaries are providing, rather than competing on the way that the payments are built around the current incentives for risk adjustment. And I know that's kind of a lofty goal, and I know that's a future state, but I do think it would be nice to start to move in that direction rather than continue to have the same arguments over and over again about coding intensity.
Fair enough. Well, I want to thank you both immensely for being here. Thank you for your insights. Thank you for being so open and honest and willing to have this conversation for everyone here. And I think we can call it a day. So thank you.